Okay, we're going to go ahead and get started. To begin with, we're going to just take a moment to introduce ourselves so you know who's who. And we'll kind of just start with these questions and see how many we can get through. If you think of another question that maybe something someone says triggers something, just raise your hand, and we have these beautiful assistants in the front here. We'll be happy to run. Oh, look, assistants. There's someone with their hand up. They'll come and collect the questions and bring them right up to us.
Again, I'm Frances. Hi, I'm the clinical case manager.
I'm Irene Malati. I'm a movement disorder neurologist.
I'm Kelly Foote. I'm a neurosurgeon who does deep brain stimulation.
Karen Hegland. I'm a speech-language pathologist.
Michael Oken, I'm a neurologist.
Christopher Hess, I'm a neurologist.
And I'm Melissa Armstrong, and I'm also one of the neurologists.
So the question is, does the social worker meet with individual families to discuss needs and to set up services? Definitely, that's exactly what I do. So usually what happens is either one of the providers or you'll self-refer. Oh, sorry. One of the providers will notice that there's a particular area that you might need assistance with, or you might tell them that you want assistance with something in particular, and then they'll let me know, and I usually call you and set up a time to meet with you individually to discuss those concerns. That's usually either during an appointment or at a later time as well. Does that answer the question?
So there's a question here about excess saliva in Parkinson's disease. We like to give things fancy names, so we call that sialuria. Sialuria meaning too much saliva. And this is a problem that can be common in Parkinson's. And it's not that people produce more saliva, it's just that we normally reflexively swallow it all the time. And just like there are muscles that make us walk, there are muscles that make us swallow, so it seems that we don't swallow fast enough to keep up with it. There are some solutions for this. Sometimes we use atropine eye drops on the tongue. So the pharmacist thinks we've lost our mind when we say eye drops apply to tongue 2 or 3 times a day, but sometimes those help a little bit. Sometimes there are things you can do that don't involve medicines, like sucking on candy or chewing gum, or keeping a bottle of water next to you and sipping periodically. So things that trigger you to swallow on purpose can help keep up with it. And in extreme cases, if there's saliva that's really pooling and coming out of the mouth, we do botulinum toxin injections. So you may have heard of Botox. That's one of the 4 brands. There are others called Dysport, Xeomin, and Myoblock. And we do injections into the parotid and submandibular glands, so on the side of the cheek and under the chin, that can be quite effective and last up to 3 months for that problem. And let's see. Somebody asked, if it didn't work for me when I tried Myoblock, does that mean it's the wrong medicine or the doctor didn't hit the target? If you're being injected by a movement disorder specialist, it's a target that's typically well known, and it's not very difficult for someone with experience to hit, so it might be the dose needs to be adjusted. And there's no treatment that works 100% of the time, so maybe trying some of those other strategies.
This question says, in TED Talks in Charlottesville, December 1st, 2015, Dr. Neil Cassell spoke about focused ultrasound and, quote, curing with ultrasound. There's some reference to The Tumor by John Grisham that I don't know about. But the question is, please address thoughts on this modality. So focused ultrasound as it applies to brain surgery, is actually a very exciting new therapy. It's new in some ways and old in some ways. Before we did deep brain stimulation, what we used to do is put a probe down into the brain in the target that we wanted to hit and burn a hole in the brain. And depending on the part of the brain, we called them thalamotomies or pallidotomies, and they were very effective, terrific operations. And then Professor Benabid noticed that if you treat someone with tremor, if you put the probe in the right spot and you do test stimulation, so, you know, this was a safety thing in the beginning, he would turn on the stimulation to see what happened to the tremor and see if the patient got weak on one side of their body or couldn't talk. And if he turned on the stimulation and the patient couldn't talk, he knew it wasn't in the right place, and so he would not burn a hole there. He would move to a different place. And we all did that. It was a safety method. And then Professor Benabid realized, you know what, when I turn on that test stimulation and it's in the right place, the tremor stops. So what if I just put an electrode in there permanently and delivered continuous stimulation? Then I wouldn't have to burn a hole in the brain. And that was the birth of modern deep brain stimulation. So it was an evolution away from burning a hole in the brain, doing intentional destruction to brain tissue, toward a treatment with a stimulator that is modifiable and doesn't cause permanent damage. So you could turn it up and turn it down, and if you happen to get it in the wrong place, it could theoretically be moved. You could take it out and put one in a better place without intentionally damaging the brain. So that's a big long-winded explanation to get us to the point of this new technology, focused ultrasound, is the best way that has ever been developed to burn a hole in the brain. So they are capable with this new technology of shaving your head really smooth and putting this device on top of the head that will deliver enough energy with focused ultrasound beams to burn a hole in a very precisely located place in the brain inside of an MRI scanner. And so you can actually watch on the MRI scanner as the brain is heating up, and it's a safer way to do it. You don't have to cut someone's head open, you don't have to drill a hole in the skull, and so if you're going to have a hole burned in your brain, this is a really exciting new way to do that. The controversial question is this a step backwards because it's still intentionally destroying brain tissue? And the experts argue about that. So there's not a right answer yet for that question. My personal bias is that right now I think focused ultrasound is going to be a terrific technology, at least for people who are not good candidates for surgical intervention like deep brain stimulation. It gives them an alternative. If, say, somebody who's 85 years old and had a heart attack last year and smokes and has diabetes, and I tell them, look, I can't operate on you because something bad is going to happen, this would give them an opportunity to have a pallidotomy or a thalamotomy to help their movement disorder. But in the future, it's debatable. It may even play a bigger role. We'll see.
So the question I'm going to answer is when and how often should I have a swallow evaluation, which is a really great question, and it's actually something we've been trying to figure out. When do you start? Problems with swallowing typically develop during some point in the disease process, but they're typically not present right when you're diagnosed. So it's not one of the first things that happens. Some of our research has shown that at about somewhere between year 4 and 5 post-diagnosis. That's when we start to see some changes to swallowing function. And so we'd like to get an idea about what the baseline function is sometime right around year 4, maybe a little bit before. And then an evaluation about once a year is what we typically do, up until the point where we see some more significant changes, decreased ability to protect the airway, and then we typically will do evaluations once about every 6 months.
So I want to just take a moment and say thank you to Amanda. Put your hand up. So Amanda is really the heart and soul of the symposium. So also to our 2 future neurologists, Gracie and Willow, for collecting all the questions for us. Okay, so a couple of questions here. There's a question on studies that are ongoing for the use of a diabetes drug called exenatide in Parkinson's disease. First, you should know that there's a big movement for repurposing Parkinson drugs. There are drugs now being repurposed from various diseases. Probably the ones that are gleaning the most attention now are actually malaria drugs are being repurposed now for Parkinson disease with some interesting research in the laboratory that's moving now into the clinic. In diabetes, there have been 2. One is called pioglitazone that works on the energy-producing part of the cell called the mitochondria. Unfortunately, that study was a good idea, but it was negative, so it was not helpful. And so that drug has been abandoned, but there's another drug. Does anybody, raise your hand if you have diabetes. Anybody here have diabetes? So in diabetes, there's a condition that happens where you become resistant to insulin. And so there's a drug that helps in insulin resistance, and it's called exenatide. And there was a thought that this drug, because of its mechanism of action, might have a positive benefit for slowing progression in Parkinson's disease. There's been a small trial through the Michael J. Fox Foundation and a follow-up trial, too small to tell, but in the group that got the diabetes drug, the symptoms didn't progress as fast. And so there's some hope that this could be a disease-modifying way to go for Parkinson's disease. A couple of other quick questions. What's known about the role of iron and copper in Parkinson's disease? Well, iron actually deposits all over the brain in Parkinson's disease patients, and we know that the metabolism of iron in all degenerative disorders, including Alzheimer's, Parkinson, and other dementia types of disorders, is off. Whether this plays into the reasons why you get Parkinson or it's an effect of having the Parkinson, we don't know. People have tried actually chelating or getting rid of the iron, and so far that has not been an effective way to treat Parkinson's disease. Copper hasn't been one that has come up in Parkinson, but it is important in a genetic disorder that lives on the 9th chromosome called Wilson, or the 13th chromosome called Wilson's disease. And so in that disease, which can have features that look like Parkinson, copper is the metal that deposits in your brain. And a question on consumption of dopamine precursors. So if you take lots of dopamine precursors, can it help you produce more dopamine? Well, it's interesting because actually Stan Fawn, who gave the keynote address this morning, many people don't know that he began his career in the 1960s as a neurochemist and had a neurochemistry laboratory and was key in making a lot of the early discoveries about how these different transmitters are taken up in the body, used, and converted. And it turns out that there are a group of plants called legumes, L-E-G-U-M-E-S. These are things like fava beans. Raise your hand. Anybody eat fava beans here? So if you chew on fava beans, they actually have dopamine in them. But it turns out you're going to have to eat a heck of a lot of fava to get any dopamine into your brain. And the type of dopamine that you need in your brain is actually not something that you get out of your diet. So let me say that again. The type of dopamine that you use in your brain isn't something that you get out of your diet. It's actually something that your body converts into the dopamine from other various things that you eat. So there's absolutely no evidence that over-consuming legumes or fava beans has any benefit, and it might make you unpopular with your spouses and friends.
Okay, so there was a question. I'm 76 years old. Should I be taking Cinemet along with Mirapex? So Dr. Fahn earlier today had given a talk for those of you who were here about common mistakes that happen in Parkinson's disease. And one of the things that he mentioned was giving dopamine agonists in people that were older, usually over 70 years of age. So the question is, this person is 76 years old. From the question, it sounds like they're taking Mirapex. They're wondering, wow, is someone making one of these cardinal mistakes with me? So in general, for the most part, if we're going to start a medication for Parkinson's disease in most people older than 70 years old, we do tend to start with Cinemet first. Now, that doesn't mean that in every case that if you're over 70, you shouldn't be on Mirapex. There are some patients who, especially patients who've been on a dopamine agonist for a while, that progress into their 70s and are still doing well with the medication. So it really needs to be taken on a case-by-case basis based on not only the age of the patient, but also what other side effects are they getting, how long have they been on the dopamine agonist, is this something that you're initially starting, or is this something that you're continuing? I've had patients together with Dr. Fahn that he and I saw together that were over 70 and were on dopamine agonists, so it's not cut and dry. In general, most of the time when you have someone who's older than 70, you do want to avoid dopamine agonists just because they're not tolerated as well.
All right, I have a couple questions that I'm going to answer together because they overlap to some degree. And the first one was, what are the resources for helping Parkinson's patients and their caregivers as the disease advances? A Parkinson's 201. And then the second one is examples of victories in the management of later stage of Parkinson's and improving quality of life. So in thinking about Parkinson's 101 and 201 and 301, I would kind of break down Parkinson's into three very broad categories, with Parkinson's 101 being the newer diagnosis. The early years, you can be managed pretty well on one or two medications. You don't have those motor fluctuations yet. And then that intermediate stage would be with medications when you have the ups and downs, or maybe you're having the dyskinesias, the wiggly movements, which relate to the medication. And then maybe Parkinson's 301 would be the later stages of Parkinson's, where the medications aren't working as well. You're having a lot more symptoms that don't respond to medication, so more trouble walking, trouble with memory and thinking. And so in thinking about the Parkinson's, I might break it down into three stages. If we think about 201 as that intermediate stage, there are so many different things to try at that stage. We have different kinds of medications, some that work directly, some that lengthen the levodopa. We have the duopa gel now that can be administered via a pump. We have the deep brain stimulation. So that 201 stage is really when there are so many different options to consider. And then at the Parkinson's 301 stage, that's when it really gets tougher to treat, and where a lot of what we do causes more harm than good. And sometimes I even focus on pulling back on medication. So maybe you're in your 70s now and you did really well with Mirapex before, but now you have some memory and thinking problems and hallucinations. And so often what we can do best at the 301 stage is pull back on medication. And sometimes we can even make you better by taking away medications that used to help you, but now may be doing more harm than good. Throughout all three stages, I think it's really important to emphasize that improving quality of life is about a lot more than just treating your tremor and your stiffness and your slowness. And that's really true throughout Parkinson's. It's important that we're treating depression and anxiety, that we're treating constipation if your constipation is, particularly if it's bad, that if you're having a lot of urinary problems, which may be part related to other aspects of your health and part related to the Parkinson's, that we're getting you into a urologist that can manage those symptoms that can really affect your day-to-day life. And so I think one of the things that's important for quality of life throughout the stages is making sure we're looking at what's impacting your quality of life the most, and that we're helping you get the best control of those symptoms that we can get. With regards to improving or getting victories really late in the disease course, what I would encourage you to do is think about what would be the most meaningful victory for you. And one example of that might be a quality gathering with your family. That gets a lot harder when you're in an advanced stage of Parkinson's and you get tired more easily. Or if you have trouble with memory and thinking, it's easier to get confused in a new place, or you're in a walker or a wheelchair, making getting around harder. But I think there's a lot of opportunities for you to make that a real victory and a really important time for your family. And some of that is involved creative thinking that either you can do on your own or that we can do with you. So one thing I encourage is for family gatherings for someone with advanced stages of Parkinson's is keep it simple. Maybe have a short time with the person with Parkinson's and memory and thinking problems, and then have those energetic grandkids, go outside or to another house for a few hours and give the person with Parkinson's a break. Or maybe if sometimes changes of routine is really hard for people with memory and thinking problems. And so trying to keep that routine as good as possible, maybe have family stay in a hotel and come over, making sure the person with Parkinson's has time for naps and breaks. And so when I think about victories, I often ask my patients, well, what would be the most meaningful for you? What do you really want? And if the answer is, I want a great Christmas with the person with Parkinson's and my extended family, let's brainstorm ways to work around the Parkinson's and make that a real victory and a really special time for your families. So the victories become a little bit less about the disease and a lot more about what's meaningful for your life.
Hello, I should introduce myself. My name is Heather, and I'm an occupational therapist from the rehab department, and I have a little bit of a scratchy voice, so bear with me. I apologize. But I'm going to answer these two questions, kind of a combined question about what is the role of exercise on maintenance of Parkinson's disease, and us as a rehab group, and I'm going to speak from physical therapy and occupational therapy perspective at the Center for Movement Disorders. We are huge advocates of exercise and the maintenance and slowing the progression of Parkinson's down. And the physicians here at our center are huge supporters of rehab. If you've been to our center, you understand that, because on your first visit to our center, for the most part, they ask you to come and see OT, PT, and speech therapy, as they recognize how important getting you on a good exercise program is to managing your Parkinson's symptoms through exercise. And the three components of exercise that have been shown to manage your Parkinson's symptoms include cardiovascular, so that includes biking, walking, swimming, dancing. We don't care what it is. Our philosophy is whatever's going to keep you doing it, we like it. So there are many studies that show, yes, biking is great, that boxing is great. Yes, they are all great done at high intensity, but if you don't like it, you're not going to do it. So if you don't like biking, then don't do it, right? If you like dancing, spend 45 minutes with some music on in the background and do it. It's great for your heart. So cardiovascular is the first component. Second component is stretching. We want you on a great stretching program. You need to stretch. The rigidity, the stiffness of your muscles can create pain, difficulty walking, fatigue throughout your day, dystonia, and we want to manage that through a very structured stretching program. And so we want you not only weight training, but we want you stretching, and sometimes that can be boring. So we want to teach you how to do a fun stretching program, whether that's through yoga, Tai Chi, or just something we show you through structured home program. And then the third component is strength training. But the good news is Parkinson's doesn't typically directly affect your muscle strength unless you just don't use your body, right? So for the most part, if you don't use it, you don't lose it. Or if you don't use it, you're going to lose it. So our goal is just to keep you active. So we want to keep you active. And that's the role in exercise. If you're going to spend your day sitting around, then you're gonna have a more debilitating day, and we don't want that for you. So getting into a good rehab program, OT, PT, is going to be critical in keeping your independence, decreasing your pain, increasing your mobility, and improving your quality of life.
So my next question is, do you give new PD patients literature on resources available to them? I think the center does a really great job at doing this. Specifically, Janet Romrell has a educational day program that she holds specifically for newly diagnosed patients with Parkinson's. So the way that they do that is that when a provider knows that they have a patient that they've just recently diagnosed, they'll let Janet know about that person, and then Janet will reach out to them and invite them to come to the day program. And the day program pretty much does an overview of everything there kind of is to know about Parkinson's in terms of medications, rehab, social work, and much, much more. So you get to learn a lot, and then she also gives you a lot of the booklets that we talked about and all the kits that we talked about, so she has those there for you as well. But you have the benefit of having us there so you can ask us questions, and it's interactive. And also there's free lunch, so there's that as well. So she has those every few months. I think the next one's coming up in June. So we'll have a round table where we involve the patients and invite them to come over and talk about, this new diagnosis that they're going to be dealing with.
And there's some of the literature from the National Parkinson Foundation is on the table that you got your lunch from, and those are always available for free at our center or online. The National Parkinson Foundation website actually has a lot of information, Parkinson 101, PD 101, and people have sent in questions over the years, and there are questions and answers available. Dr. Oken is the director of the National Parkinson Foundation, the medical director, and he makes a column once a month of what's hot in Parkinson's, so that's good for people to get updated on. So I'll answer one question here. What is the relationship between Parkinson's disease and idiopathic neuropathy? So Parkinson's by itself does not cause neuropathy. Neuropathy is a problem where the nerves do not conduct properly and people can lose sensation, they can have burning and tingling, sometimes they can have weakness. Parkinson's itself doesn't cause that, but one interesting thing emerged in our Duopa studies, that's the continuous infusion of levodopa gel, that some people became deficient in B vitamins and that potentially caused neuropathy. So that would be the only relationship I could come up with, is to make sure you're not deficient of vitamin B12, and those are things that a doctor could order and check. And piggybacking on that, some questions about Duopa. Duopa is continuous duodenal infusion of levodopa. What that means is, instead of taking pills periodically throughout the day and having benefit that kicks in and wears off and kicks in and wears off, a little tube is put in that stays in permanently and attaches to a pump that you carry around, and it continuously, 16 hours a day, infuses a steady level of levodopa. So for some people, there's an advantage in that they have steady blood levels and less fluctuations. Of course, any procedure has some risks, so having a tube in the abdomen has some risks like infections and blockages and so forth, and it's not the right therapy for everyone, but for some it's very good. The question was, can Duopa be used with DBS surgery instead of taking pills? So that's sort of a two-part question, and the first part is, can someone who has DBS subsequently have Duopa? And the answer is yes. There's not a direct contraindication. The two operate independently. Will it replace taking pills? And that's something that has to be looked at on an individual level. Some people who have Duopa continue to supplement with pills, maybe overnight when the pump is turned off. And so it's still a medicine, it's still levodopa. So once a person has that, they may or may not require additional pills in addition to the Duopa being infused. And the other Duopa question was, what is the difference between Duopa and Apokyn? Apokyn is the brand name of a medicine called apomorphine, but it's not like a narcotic like morphine. And this is along the lines of a dopamine agonist, so it's an injectable rescue medicine. And the role of Apokyn is typically for somebody who may have a very good response to their medicine, but sudden wearing off. They could be in the middle of the store, in the back of Walmart, and bam, they can't walk. The medicine suddenly wore off. And that would be a situation where an injectable, quick-acting and short-acting rescue medicine could be useful. That therapy has to be initiated in the clinic. That means the first dose has to be observed so we can watch blood pressure and make sure everything goes okay. So Duopa is a daily maintenance therapy that a person would have running all the time, whereas Apokyn would be an as-needed rescue injectable medicine. So those are the differences. So Duopa is indicated in a person with fluctuations. It might kick in and they have dyskinesia and then it wears off, on and off through the day. Apokyn is for someone who suffers from sudden wearing off. We'll go down the line and we'll just keep coming back.
A few people asked questions about who should have deep brain stimulation. There are several questions that are essentially related to that, and I'm glad that you asked. One of them says, what is the major factor you have to consider to qualify for DBS? And I'm glad you asked because that was the part of my talk that I didn't get to. So I will give the rest of the 6-hour talk now. It's a risk-benefit analysis. You approach this question just like you would approach any other big decision in your life. And it's a big decision because it's elective brain surgery. So most of the time, if you're going to have brain surgery, it's because if you don't, you're going to die. It's because you have a ruptured aneurysm, or if you were in a car accident, you have a head injury, or you have a brain tumor, or something like that. In this case, we're talking about doing brain surgery, and you're not going to die if you don't have it. You're just going to keep going on the way you're going on. So the first criterion is the problem has to be bad enough to warrant brain surgery. Most of the time, frankly, we don't get a lot of crazy people. We don't get a lot of people who come wanting brain surgery when they don't have a problem that's bad. So, I mean, I joke about it, but the truth is people don't ask for it unless they've got a bad problem. So it's all about quality of life. And in the bottom line, if the answer to this question, what's the major factor? It has to be, we need to consider all the variables, and there are a bunch of complicated variables that go into the decision-making process. They all relate to what are the risks and what is the predicted benefit. And we need to become convinced as a group. I don't make these decisions by myself. That's too much pressure. I make these decisions with a committee. And guess who the committee is? It's these guys. Every person who is referred for deep brain stimulation surgery is evaluated by a movement disorders neurologist, a physical therapist who's a specialist in movement disorders, who's seen lots of patients go through the brain surgery and the DBS and knows what kinds of things it helps and what kinds of things it tends not to help. The occupational therapist, the speech and swallowing experts, and now the social worker. In any case, the psychiatrist sees everyone before, and the neuropsychologist. One of the questions related to dementia, and that's a special case, I think, but it all factors into the same thing, risk analysis. And so all these different specialists evaluate your risk. My part's easy. My part is, the older you are, the higher the risk. That's just the reality of human existence. None of us are 20 years old anymore. So I factor in things like age and your general health. And inevitably, every time I give a talk, someone says, well, what's the age limit? And I'll tell you, there's not an age limit. I would much rather operate on a healthy 75-year-old than an unhealthy 65-year-old. Okay, so there are a bunch of factors that go into this decision-making process. And we have developed, over the last 15 years of research on this particular operation for Parkinson's disease, ways of minimizing the risks and maximizing the benefits, and different ways to do the operation depending on a certain patient's risks, because they're different, people are different, and the type of benefit. So if you're a motor fluctuator, like we talked about earlier, and you're spending your day going back and forth all day long between able to move and not able to move, then DBS offers a terrific possibility of getting at or near your best functional state and staying there much more of the time, so alleviating those motor fluctuations. You could try doing that with duopa, which is a similar idea, right? Less fluctuation. And that might work as well. Patients who have severe tremor that doesn't respond to the medication, frequently it responds nicely to the surgery. Patients who have severe dyskinesia as a result of their medication respond beautifully to DBS. And so, the indications in every patient are a little bit different, and we might change the way we do the operation to minimize the risks in a given patient. Now, just to make sure I address the one question that the person asked about dementia, dementia also comes in all different flavors. As we get older, our brains don't function as well as they used to. There are certain types of dementia that put people at high risk. So for certain types of dementia, you should never have any kind of brain surgery, even minimally invasive brain surgery like DBS, because what you would never want to do is say, I have a terrible tremor, and I go and I have a terrible tremor and I have mild dementia, but I'm able to manage okay. And then you go and you have an operation and you trade. Now I have a perfectly steady hand, but I'm in a nursing home because I can't remember who I am or what I'm doing. Okay, that's a terrible trade that no one would intentionally make. And part of the neuropsychologist's job on our team is to evaluate your cognitive risk. And so I rely on them fairly heavily to make recommendations about that. So dementia can mean a lot of different things. And certainly we operate on people all the time who have some brain dysfunction in the cognitive domain. But certain types of dementia would actually preclude you from having this sort of surgery. But it all comes down to risk versus benefit analysis. And we all have to sort of come together and decide collectively that we think this is in your best interest, and that there's an overwhelmingly high likelihood that if we did this brain operation on you, that your quality of life would improve substantially. And if we can't convince ourselves of that, then sometimes we'll say, this is not a good idea for you. We're afraid that we would hurt you more than we would help you. Bottom line is we have a terrific process for evaluating people who are referred for deep brain stimulation. You go through 2 days of meeting all the key members of our team. You learn a ton. And then in the end, we'll do a risk-benefit analysis together and decide with you if it's a good idea. I only took about 4 hours out of my 6.
Okay, so I'm going to answer a question, and then I'm going to answer a question that I want to answer, kind of resulting from this question. It's a little bit outside of my wheelhouse, but Dr. Malati has coached me on how to answer appropriately. So the question's about Parcopa versus dissolving Sinemet in the mouth, and whether there's any differences or if one is better than the other. And I'm told that the answer is that they're the same, that there aren't any differences, that Parcopa is basically the same kind of drug and doing. Yes, it's a Sinemet that melts in your mouth. That sounds nice. But what I wanted to answer about this is something about pills, because when we do our swallowing evaluation, that's always a question that we get, because people with Parkinson's disease take a lot of pills, whether they're related specifically to Parkinson's or to something else. And so if you're having difficulty swallowing, but you have to take your 27 pills in a day, how do you manage that? And what we hear a lot is that you put a bunch of pills in your hand and you toss them back. So taking many, many pills at one time. And the trick here is that you have to strike a balance, right? You don't want to spend your entire day taking pills one by one, but you also don't want to put yourself at risk for those pills going down the wrong pipe. And so there are a lot of things that we can kind of suggest that might help you manage taking all of those pills. Some pills can be crushed, okay? So you can crush them up and mix them with something like pudding or applesauce to kind of disguise the taste and help things go down a little bit more effectively and safely. If you have very large pills, try not to take those in conjunctions with the smaller ones. So if you're going to take multiple pills at one time, don't make one of them a really huge pill. Try to do smaller so that there's just not so much going down at one time. Do try to take pills with some type of liquid. We don't tend to recommend thickening liquids very much. We try to save that if it's really, really sort of in dire need of having the liquids thickened. So you can just take pills with regular old water as opposed to taking them dry, so just not with any sort of liquid at all. If you have pills that can't be crushed, and sometimes they can't if they're, kind of in the capsules where they have a specific, I guess, release that has to happen once they dissolve, you can put those in, you can actually just take that little capsule and put it in some pudding and just mix it with the pudding and take it that way. And so there are different ways to manage the pills. What we really try to discourage people from doing is that, putting 10 pills in your hand and trying to take them all at one time. That's not really a good idea for anybody, and it's definitely not a good idea for somebody who has a higher risk of having a swallowing problem.
Just another small comment on the Parcopa question. I think the person may have been wondering, is it better? So Parcopa is just orally disintegrating, meaning melting Cinemet. It's not any better, it doesn't kick in quicker. It's just that it accomplishes getting it melted so you can swallow it more easily. So for a person who has difficulty getting pills down, that's the main advantage. Or somebody who has wearing off in the middle of the night and would like to be able to just reach over and put one in their mouth that they don't even need a cup of water to drink down, it could be a potential indication.
Chuck Jacobson, thank you for helping us with all of your technical skill today. So we really appreciate your help. So we get a round of applause for Chuck. Also, this has been brought to my attention that this is the 13th straight symposium, and I think the only person that's done all 13 is Janet Romrell. Are you still here, Janet? So, oh, she just left. All right, well, congratulations, Janet Romrell, 13 straight. Has there been any success with stem cell implantation to produce dopamine? The answer is yes. We can make stem cells. We can make the stem cells produce dopamine. We can put the stem cells both into animals and into humans, but this has not, in general, been a successful approach as a treatment for Parkinson's disease, because Parkinson is too complex to just think that you can transplant any cell. And the idea that stem cells are the cure for Parkinson has been around for about 15 years now. People have raised a lot of money around it and said we're going to cure Parkinson in 5 years. Hasn't happened, and the reason it hasn't happened is it's very hard to get the stem cell to go where you want in the brain and to do what you want. It's kind of like your kids. You saw I couldn't control my kids when they were right here. So it's the same deal. However, there are some promising uses of stem cells for drug screening. We can do large throughput screening of FDA libraries for things like malarial drugs and things that might show up on screens that would be important. And then I'll just draw your attention to an interesting and evolving area of Parkinson research, and now moving into the clinics for vaccines and for therapies plus, so deep brain stimulation plus growth factors, stem cells plus growth factors, vaccines plus symptomatic therapy. So it may not be a one-size-fits-all, and it may not be a magic bullet here. So that's the update on stem cells.
Okay, so we have a question. What are the downsides to postponing taking medications in early onset PD? So you heard from Dr. Fahn this morning. He was talking about the timing of when to start medications, and he talked about levodopa. He talked about the complications of levodopa. Did you want to expand on that? Or? No. So he talked about the complications of levodopa. And so what can sometimes happen is people hear about, okay, motor fluctuations, dyskinesias. Wow, I don't want to take any medications early on. I'm going to wait till the last possible minute. And if you think about it, what are we doing this for? We've talked about the fact that none of the medications that we give you have ever been proven to slow down the course of the disease. We can't cure the disease. We can't slow down the course of the disease with the medications. So what are we doing this for? We're taking the medications to improve your quality of life, right? That's the purpose, to help control your symptoms and to improve your quality of life. So there are two things that can sometimes happen. One is very analogous to when I was a little kid. I didn't go trick-or-treating very often, but when I did a couple of times, I would gather up all my candy and I would divide it into what I liked the most, put it on the end, and then what I liked the least. And I would start at what I liked the least because I wanted to save the best for last. And I would notice that by the time I ate all the candy and got to my favorite stuff, I wasn't hungry anymore. And I sort of missed out on all that was in between. So what sometimes happens with patients, you can push the medicine back further and further and further, and what you're doing, what you're losing, is quality of life and symptom control over that period of time. The other thing that can sometimes happen is, you heard Dr. Fahn talk about levodopa or dopaphobia. Hearing about the onset of these motor fluctuations and dyskinesias can, again, push people to try to push off their medicines for as long of a period of time as possible. But if you remember from Dr. Fahn's talk, what were the risk factors for motor complications? So it was the time you'd been on levodopa, the levodopa dose, but the total disease duration was by far the most important risk factor. So if you push off your medications for too long and you go through a period where you could get an improvement in your quality of life, but you don't make use of that, you can just catch up later on anyway. And there were studies that were done in people who did not have access to levodopa, and those patients who started levodopa much later in their disease just caught up with many of the other patients. So it's important so how do you make the decision? You make the decision based in a combination. It's a decision you make with your doctor. You're relying on the doctor's experience. You're relying on what you feel is best. It's a joint decision, but you want to make sure you're not making one of those two errors, trying to save the best for last or being afraid of what's really been the best medication that we have for Parkinson's.
So we're now assembling a list of volunteers of people that are willing to take Dr. Hess trick-or-treating with them next year. It's October 31st is the day that that happens, and in Britain you actually have to do a trip to get your treat. So in America it's actually pretty easy, Chris. Dr. Foote reminded me that has anybody here ever considered if somebody came to you and said, I'll cure your Parkinson disease, it costs $50,000 or $100,000. Has anybody ever thought about doing one of these? By a show of hands, has anybody ever heard about these therapies that are here in the US and mainly overseas, where they'll offer you a stem cell cure for $50,000 or $100,000? Anybody thought about it? I mean, most people will think about it, right? When you have a disease, you'll think, gosh, I would do anything. And if you have a spouse, if you're a spouse of somebody suffering from a disease, you'll do anything for your spouse, and you should. And that's the way that it should be. The field in stem cells is called stem cell tourism when that happens, and And so the things that I tell patients to be weary of, and it's not just in stem cells, it's fill in the Mad Lib. It can be any therapy, it could be vaccines, could be anything that is not got an FDA approval mark on it already. You should not pay for that. It's research, okay, number one. And you should be consented. They should be paying you to be in the study. You shouldn't be paying them. And if it was a proven therapy, it should be on the market, particularly with the dangers that are associated with those therapies. These things are still in research. It doesn't mean you shouldn't volunteer for research studies, but when you see these things, they've all been proven to be sham types of therapies designed for people to make money. I know that's shocking that people would want to make money off of you. I know it's totally shocking that anybody could be that dishonest or immoral, but it does happen, and we have a number of patients in the practice that have done these sorts of things, and they go for tourism for various things. So just ask one of us if you want to know about a therapy. Trust me, we will be the first ones to let you know if you should go get something, because we got other things we want to do after we cure Parkinson's. So.
All right, I have a couple quick questions about experimental therapy and new therapy. So one question was about isradipine in the treatment of advanced Parkinson's. Isradipine is a calcium channel blocker that is approved for the use of high blood pressure. We don't use it very often for high blood pressure anymore because we have so many treatments for high blood pressure, but it is technically on the market for high blood pressure. It hasn't been studied very much yet in advanced Parkinson's, but it is in a trial here in the US for early Parkinson's. This is Parkinson's for people who aren't on any medication yet, with the hope that it might slow down the progression of Parkinson's, which is easiest to study in people who've just been diagnosed. That study is ongoing. It's a 3-year study, and they're looking at the impact of the isradipine over 3 years, and so it's still going to be a little while before we have those results. And in general, I don't know any Parkinson's specialist who's recommending trying isradipine off-label for Parkinson's, because right now we really don't know if it's going to do anything at all. So even if you have high blood pressure, I usually encourage you just to work with your doctor to figure out the best blood pressure medicine for you and not worry about isradipine until we know a little bit more about it. The other question is about the new drug, Rytary, which was just FDA approved last year, so we've had it for a little bit more than a year now, asking about how it's different from Sinemet and who it might help. So it is just another form of Sinemet, or carbidopa-levodopa, and the difference is that it is 1 part of the immediate release carbidopa-levodopa and 4 parts of an extended release carbidopa-levodopa. Now, some of you may know we have Sinemet CR, and that's been around a while, but that old form of Sinemet CR is really erratic. It may kick in right away, it may take a while to kick in, very rarely do you absorb all of it, so you don't get all of the dose. And because it's erratic, and we know the timing of medicine is really important for people with Parkinson's, we don't use Sinemet CR very often. The new form is supposed to be more consistently absorbed, and it's this combination. So you get that immediate release kicking in right away, and then you get the sustained release kicking in over time, so it should work both right away and on an ongoing basis, such that you would only need to take it 3 to 4 times a day. But still, in essence, it's the same thing. It's levodopa-carbidopa. It's just how it's formulated. It's probably most useful as one way of treating wearing off, because it lasts longer, so you should have less wearing off. That being said, I think there are still a lot of challenges for us in learning how to use it well and when to use it best. So there is a conversion table where if you wanted to switch to this, we would add up all of the levodopa-carbidopa you're taking, we would put that dose in the table, and we would see what dose of Rytary you should be on. Well, even in the research, 60% of the time, that was the wrong dose. So people either needed more or they needed less. Being on the wrong dose is a little bit problematic because it comes in capsules, so you can't break them in half, and they're really weird doses. So there's little doses, there are big doses, but when you make the switch, the recommended dose that you go to is either 3 to 4 capsules, 3 to 4 times a day. So very rarely is it going to be less pills for you. It's just going to be less times. So that would mean you take 3 capsules of Rotari in the morning, 3 capsules midday, and 3 capsules in the evening. Or sometimes you switch to a dose that's 4 capsules in the morning, 4 capsules at midday, and 4 capsules in the evening. And there isn't a good way to just say, well, instead of using 3 of the little one, let me use 1 of the big one. That hasn't really worked out so well. And so what I caution people is it's a nice addition to our Parkinson's options. It does seem to last longer than the regular levodopa carbidopa, but there are some real challenges in using it. The switch isn't as smooth as we'd like it to be. You still are taking a lot of pills. It can be very expensive depending on your insurance plan. And a lot of taking care of Parkinson's and medication is an art. We've had experience over many years figuring out how to use these medications and adjust them. And this is a brand new medicine, and so it takes some time to develop that art, figuring out how to use it best. So I think it's could be one useful addition to the drugs we have, but when people come to me in clinic, I do caution them that it's not all just a bed of roses, but there are some real challenges to using it well.
Okay, so since we've run out of time, I'm going to take this last 2 short questions, and there are a few we may not have gotten to. If you have one you didn't hear the answer to, please grab us afterwards, because we know people may have other places to be. One question was, does Parkinson's cause dry mouth or do the medicines? That would usually be the medicines. Also, normal aging, some people experience dryness of the mouth. So if this is a bothersome problem, you may talk with your doctor or healthcare provider about adjusting your medicine. Also, sucking on lemon drops. Lemon drops are called a sialagogue. That means they help your mouth drool a little more, and they can add some moisture at certain times, or drinking sips of fluid periodically. And there are some mouthwashes that can add moisture to the mouth. And the final question is, tell me about Parkinson's and eye problems. You might have noticed Parkinson's doesn't just stick to the brain or the tremor. It actually affects a lot of different body systems. Some of the more common problems that we can see related to the eyes are blepharospasm, which would be an excessive blinking or even spasming of the eyes. That can be treated with botulinum toxin injections of the muscles that close the eye. There's another condition called apraxia of eyelid opening, wherein the eyelids don't open when you tell them to, kind of like freezing of gait, but eyelid opening. It's much more rare, and it's also treated the same way. Somebody sent a different question about my eyes are open too wide. That's an unusual situation, and I would encourage you to address it directly with your doctor so that could be explored a little bit. You might be experiencing the less blink rate that we sometimes see in Parkinson's, and your eyes may feel dry and give you an impression that they're too widely open when maybe they're just not blinking frequently enough. Also, muscles move the eye, just like muscles move our body. So if your muscles aren't moving as efficiently as they should be, it is possible to experience problems with vision, particularly one called convergence insufficiency, which means when you're looking far away and then you try to look close, that your eyes may not efficiently do that change that they're supposed to, that allows you to refocus. Rarely, some people may experience double vision, which is one of the questions that came up. And there is a specialty called neuro-ophthalmology. Neuro-ophthalmology is a crossroads between neurology and ophthalmology, eye doctor and brain doctor, and these are people who specialize in neurological conditions affecting the vision and sometimes can try prism lenses and different things that can correct double vision. So thank you so much all for coming. We just love to spend this time with you on the Saturday once a year. If you have feedback for us, things you really liked and things that you wish we'd repeat or wish we would add or not repeat, please give us that in the feedback questionnaire. And have a great rest of your day.